posted for transurethral resection of prostate with a symptomatic benign prostatic hyperplasia, a known case of diabetes, hypertension, and with a permanent pacemaker, sir. The patient is apparently normal before 2 years, after which he developed difficulty in passing urine, which is associated with a poor stream of urine and increased frequency and nocturia. History of presenting illness: the patient has been the patient is apparently normal before 2 years, after which he developed difficulty in passing urine, which is progressive in nature and is associated with a nocturia. There is no history of fever, hematuria, or acute retention of urine. Past medical history: he is a known hypertensive for 5 years under regular medication, known diabetic for 10 years under oral hypoglycemic drug. He is on permanent pacemaker, which is implanted 3 years ago for sinus bradycardia. No history of coronary heart disease, stroke, bronchial asthma. No history of chronic kidney disease. Past surgical history: pacemaker is implanted 3 years back. No history of previous anesthetic complications. Drug history: he is currently on bisoprolol, telmisartan 40 mg HS, and he is on oral hypoglycemic drugs. He is on antiplatelets, aspirin 75 mg OD. There is no known drug allergies. Personal history: he takes a mixed diet. He is having adequate sleep pattern, normal bowel and bladder habits. Normal bowel habits. He has a disturbed difficulty in passing urine. He is not an alcoholic or smoker. General physical examination: he is conscious, oriented, moderately built and nourished. Pulse is 75 rate per minute, which is regular. Blood pressure is 130/80 millimeters of mercury, measured in the left upper limb in sitting position. Saturation is 98% in room. No pallor, no ictus, cyanosis, no clubbing, no pedal edema. Systemic examination: cardiovascular system, S1, S2 here normally. Pacemaker rhythm is present, no murmurs. Respiratory system: bilateral air entry is equal, no added sound. Central nervous system: no focal neurological deficit. Airway assessment: mouth opening is adequate, Mallampatti is 3, neck movements is adequate. He has a normal dentition. Investigation: routine. Coming to the summary, sir, case summary.
Yeah, go ahead.
Yes, sir. A 70-year-old male, Mr. Ravi. He's a normal built person, posted for transurethral resection of prostate with a symptomatic benign prostatic hyperplasia with comorbidities of diabetes and hypertension with permanent pacemaker in situ.
Okay. So this case can be kept as a long case or a short case also. Okay. Majority of the times they keep it as a short case, so that just like last class, I'll straight away go ahead and show my presentation, which will contain question and answers type. So the questions you can answer. If you are not able to answer, we'll show the answers also. Okay.
Yes, sir.
Right. Are you able to see my slides?
Yes, sir.
Super. So, this is a case history: 70-year-old male with history of DM and hypertension, also has a pacemaker in situ. So, what are the challenges in these cases?
He comes under a geriatric group, sir.
Age group, very good.
He has comorbidities like diabetes, hypertension. He has a permanent pacemaker in situ, and TURP surgery involves can lead to a TURP syndrome, sir. And the positioning of the patient is in lithotomy. It would be a concern, and these patients may go for post-operative complications. Also,
What about pacemaker and this surgery? That is the most
Pacemaker
important catch
also
in
has
this image.
pacemaker
the
also has
pacemaker.
its concerns
Why?
in using that electrocautery and all.
Diathermy and all we are using.
Diathermy.
Ecthermy and all. Okay. What do you call that?
Electromagnetic
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 interference,
interference.
EMI. Okay. Not equated monthly installment, but electromagnetic interference. That is a very important. So how to manage that is also part of the challenge. So it is not coming fully. What are the features of a prostate gland? So I don't know why it's not coming fully. Actually the problems are the geriatric age group, as you rightly said. Second problem is the comorbidities of long-standing diabetes and hypertension, which can produce target dysfunction, and special problems inherent to TURP surgery, along with the pacemaker in situ being the problem in malfunctioning of the pacemaker can happen. Okay. So now we start with the basic anatomy of the prostate gland. What are the features of prostate gland? How many lobes are there? What is the blood supply? What is the nerve supply? What is its function in the male? Can you answer those questions?
It has a median and two lateral lobes, sir, and the mid.
So there are only 3 lobes.
The median to lateral lobes is most common to undergo benign prostatic hypertrophy, and it's supplied by prostate cells, which arises from the inferior hypogastric nerves, and also it receives innervation from S2, S3, and S4, and prostate is surrounded by a fibrous sheath, and it has a plexus, venous plexus surrounding it.
What is the arterial supply? What is the venous drainage? Always when you say the blood supply, you have to describe that in terms of arterial blood supply as well as venous drainage of that particular organ. So where do you get the arterial supply from? Is it a single vessel or there are multiple vessels?
Multiple vessels.
Multiple vessels. But what is the major vessels which give the? Is there a direct prostatic vessel? Is it supplied by any artery called prostatic artery?
No. No.
Then what are the branches or what are the vessels that supply the prostate? What is the importance of this blood supply to prostate to as anesthesiologist for you?
It is a highly vascular.
Highly vascular. So intraoperatively as well as postoperatively, there is always a chance of bleeding, isn't it? So unless the surgeon is very careful in coagulating all the bleeders, we can expect a post-op hemorrhage or even intraoperative hemorrhage. And what is the difficulty in TURP surgery if there is an intraoperative hemorrhage? Will you be able to identify it immediately?
No, sir.
No, sir.
Continuously sending
Why
irrigation.
identifying the hemorrhage or volume of blood loss is difficult in a TURP surgery?
It's always diluted with the irrigating fluids, sir. So
Fantastic. Okay, so the irrigation fluid is always mixed with the blood, so you cannot exactly assess the quantum of blood that the patient loses, unlike your abdominal surgery where you can obviously see the bleeders filling up in the abdominal cavity or a limb overt bleeding will happen. Whereas here, because it mixes with the irrigating fluid, it's very difficult to assess the blood loss. So the major vessel supplying the prostate gland all come from arterial supply, come from internal iliac artery. So what is the importance of that? Supposing there is a uncontrollable hemorrhage, what is the ultimate treatment? Supposing a patient has a postpartum woman has uncontrolled hemorrhage from the uterus.
Will ligate that.
You can
ligation
ligate
of
the
internal
internal
iliac.
iliac. Same thing can be done for prostate also. There is an uncontrolled hemorrhage which is not getting arrested by your ordinary techniques of coagulation and giving replacing blood, all these things, they don't work. Ultimately, you have to plan for either embolization or ligation of the internal iliac artery. Similarly, venous drainage also goes through the internal iliac vein. Okay, and what is the importance of that venous drainage? How does TURP syndrome occur?
It's
Many of the prostatic venous sinuses open up, sir, actually.
so the irrigating fluid will.
How does the fluid enter the system, systemic circulation? What is the reason for the irrigating fluid entering into the systemic circulation? How do the
Absorption
irrigation
of
fluid
that.
go into the bladder?
Through the only it will enter. So,
No. Why this fluid enters the venous plexus? That's the question I'm asking.
the pressure we are giving while
the height of the
yes, the height
irrigating
of the
fluid
irrigating
column.
Height
Okay?
of irrigating fluid.
What should be
Height is-
the correct height? Safe height.
the pressure should be around
60 centimeters. Height is 60 centimeters.
60
Okay?
centimeters.
The maximum height you can keep it is at 60 centimeters. At that time, the absorption will be minimum. You keep it more than that at a very high level, then the pressure also will increase because of gravity, and it will force the fluid to enter into the low pressure venous sinuses. Okay, that's how the TRP syndrome. So it is one of the important things to make sure that irrigating fluid stand is not very high. Okay, that is a very important thing that we have to do. So these are the prostate is an exocrine gland surrounding the urethra, the males at the origin of the urinary bladder. Okay, it is close to the junction where the urethra starts from the urinary bladder. And what is the normal weight of this?
20
weight
grams.
of max 20. Okay, maybe anywhere between 11 to 16 grams. And what is the function of this? Why is the prostate gland is there in males? What is the function of the prostate gland? What will happen if it is removed before the person attains puberty? Not studied that at all? You don't know, say no.
Sir.
Then
No,
we
sir.
proceed
No, sir.
faster.
No, sir.
It secretes a milky white alkaline fluid which contributes to 30% volume of the semen produced by the testicles. Okay, it helps in and this fluid only helps in the survival of spermatozoa after ejaculation. When the coitus takes place and it is ejaculated into the vagina is an acidic medium. So the acidic medium, the spermatozoa will die. Whereas this fluid contains an alkaline pH. So it helps in the survival of the spermatozoa, which have to then enter through the cervix of the woman to go into the uterus and then go into the fallopian tube and then form the union with the ovum to produce a zygote. Okay, so phosphorus plays a very, very important role in the survival of the spermatozoa. And it has a considerable amount of smooth muscle also. The gland has got a considerable amount of smooth muscle, which only helps the male to ejaculate the semen. So there are two functions of the prostate gland. One is it helps by producing an alkaline fluid to make the spermatozoa survive after ejaculation, and then it helps in the ejaculation also by the smooth muscles that are present in the gland. And it has got actually 5 lobes, not only median and 2 lateral, but they have an anterior and posterior also. So if you see this picture, you can see a nice diagram, which is a transverse section as well as a sagittal section. Okay. So in the transverse section, you can see the urethra is in the center, and this pink substance is the median lobe. And you have the 2 large lateral lobes, which are purple in color. And you have a slight greenish or fluorescent color is the anterior lobe, and the blue color is the posterior lobe. And you can see this is a vertical section where the length of the urethra is shown, and it is surrounded by the glands lobes like this. And the ejaculatory duct goes through the lateral lobes. Okay? So they are also part of the gland. So which lobes cause what type of problem when they enlarge? What is the significance in the treatment? Now you said the 2 lobes which will commonly enlarge are the median lobes and median lobe, which is a single lobe, and 2 lateral
And 2
lobes.
lateral lobes. Yes.
They only commonly enlarge. What is the problem that will happen if only median lobe enlarges, and what will be the problem if both the lateral lobes enlarge, or all the 3 enlarge for that matter? Because as you see from this picture, anterior and posterior are very small, and their enlargement normally does not occur. So if a person sometimes can have an isolated median lobe enlargement alone, in that case, what will happen? From this picture, can you see?
Yes, sir.
Yes, sir.
It will compress the urethra. Yeah.
So that will be called as a bladder neck obstruction. Okay, it will obstruct at the neck portion only, BNI. So they do what is called a bladder neck incision, which is a very minor procedure compared to the TURP, where you have to resect a large portion of the gland. So if the lateral lobes enlarge, they will compress the entire longer length of the urethra. Whereas if the median lobe alone enlarges, it will obstruct at the outlet. So that is called the BNI, or bladder neck obstruction, for which the surgery is simpler. So isolated median lobe adjournment produces what is called bladder neck obstruction, which can be treated by bladder neck incision. Whereas enlargement of the 2 lateral lobes cause narrowing of the entire proximal urethra, which will be relieved only by resecting the gland, which is called TURP. Okay? So this is a very important anatomical knowledge that you should have. Now, what are the histological zones of prostate gland, and what is their importance?
So, central zone and
how many zones are there?
3 zones.
3 zones are there, plus additional 1 zone, which is actually not prostatic tissue, but it is a fibromuscular portion, okay, which helps in the ejaculation. So what are the 3 zones? Very easy to remember.
Transitional, central, and peripheral.
Central, peripheral, and transitional. If you remember that, it is easy. There is a central zone, there is a peripheral zone. In between the 2, you have what is called the transitional zone. So why should you know about this histological feature? What is the importance? Can men get a cancer prostate?
Yes, sir.
Yes, sir.
Where does it arise from? Which histological zone gives rise to cancer prostate? Commonly.
Peripheral zone will be the
Peripheral zone, yes. Which zone causes the benign enlargement of the prostate? Central zone.
Transition.
Because very close to the urethra. Okay. The peripheral zone is a subcapsular posterior aspect, surrounds the distal urethra, and it is the site for cancer prostate. Central zone, which contains the ejaculatory duct also, or surrounds the It is only 2.5% of the cancer prostate arise, and it is, it is a transitional zone which surrounds the proximal urethra, which goes during whole of life, and that is responsible for the benign hypertrophy. And there is a fourth zone which is called the anterior fibromuscular zone, which is made up of muscles and fibrous tissue, which only contribute to the ejaculation. So if you see this picture, this is the fibromuscular zone. This is the transitional zone which is surrounding the urethra. And the enlargement of this transitional cells only causes the benign hypertrophy. And the central zone is little away from the transitional zone, and peripheral zone is the outermost. And the compression of the peripheral zone cells only produces what is called the false capsule. Actually, it doesn't have a normal capsule like other gland, but the thin portion, which is the extreme outside portion of the peripheral zone, only causes. That is why sometimes what happens when they keep on resecting, the surgeon is not well trained, he may puncture this capsule. Okay, so what will happen if they puncture the capsule?
Prostatic venous sinuses will open.
Venous plexus are all over there. Already they will be opened once you start. Because the plexus means it's a network. There is not a single vein which is coming. There are multiple branches which form a network. That's the plexus. So as soon as they start resecting the gland, the plexus open and the bleeding will start, and they will be going on coagulating it and proceeding. But when they puncture this portion, this outer portion, what can happen? Now they are using the irrigating fluid through this urethra.
Extravasation of the
extravasation of the fluid will happen.
in the perineum. Okay?
So either perforation of the bladder or perforation of the capsule will lead to extravasation of the irrigating fluid, producing a lot of post-op sepsis or pain. And intraoperatively, can the patient feel the pain if supposing the bladder is perforated by the surgeon?
Yes.
How does that happen? What is the mechanism? He is under spinal anesthesia, and all the spinal roots. But you said the nerve supply comes from T12 to L2 and S2 to S4. All that is blocked, but still the patient can feel the pain. How? If there is a bladder perforation, how can the patient perceive the pain, and what type of pain he will have? Will he have pain in the lower abdomen or urethra or elsewhere?
It's a referred pain over the shoulder. Periumbilical.
Fantastic. He will have a shoulder tip pain. Because why?
But inferior hypergastric nerves, or T10 to
Inferior hypogastric is formed by this T12 to L2. That is the supply. What is covering the dome of the bladder? In your basic anatomy lecture, they would have taught you. Is there a peritoneal covering?
Yes.
Huh? Yes, there is a peritoneal. The top portion of the bladder is covered, just like your uterus being covered, even though it is called extraperitoneal organ. The top portion has a peritoneum going over it, isn't it? So along with the bladder wall, the roof, the peritoneum also will be punctured or perforated. So that will cause the shoulder, just like your diaphragmatic pain occurring in lap cholecystectomy, where there is a peritoneal this thing covering. When the air accumulates there, patient will get. That's why we are not able to do tap surgeries under regional technique, because patient may experience this shoulder tip pain because of the distension of the peritoneum. Okay, so similar to that, here also patient will have shoulder tip pain, which should give you a clue that you can sometimes caution the surgeon, sir, please check whether you have perforated the bladder, because patient is complaining of shoulder pain. Okay? And what will be the other features of perforation? Apart from patient complaining.
Abdominal distension.
Abdominal. Before that?
Patient may have
Abdominal
bradycardia.
distension will take some time. Huh?
Bradycardia.
Bradycardia. What will be the immediate clinical effect as he is doing the surgery? Supposing he has perforated the bladder. He is a new surgeon, he is learning. He has pushed the resectoscope too far inside and he has perforated the bladder. Patient complains of shoulder pain. You caution him. What will be the first effect of that? Will he get an adequate return of the irrigating fluid after as you get it in an intact bladder? Every time, you know, all of you would have watched TURP surgery by this time,
Yes,
I'm sure, isn't it?
Yes, sir. Yes, sir.
So after making a few resections, they remove the resectoscope and let out the fluid and then again restart, isn't it? So whatever amount they have irrigated, that they should get back that amount in the kidney dish, isn't it?
Yes, sir.
So if it is partly going into the peritoneal cavity, will we get the complete return?
No, sir.
No, sir.
Ah. So failure of adequate return of the irrigating fluid is the first and foremost feature of bladder perforation. Okay, then only slowly every time if he continues with that, the fluid will start seeping through that hole into the peritoneal cavity and the lower abdomen will start swelling up, and you can see the swelling in the lower abdomen, especially in thin patients. You can easily find out that. Okay, so that is an important point that you have to know. And these are the, and this person McNeil 1968, he only classified these zones, and this is the importance of that. And these are the three zones he mentioned, and that is the important thing. So how does BHP occur? Already we have got that answer in that, but what is the molecular feature or molecular basis theory for enlargement of the prostate? It doesn't happen in every individual, isn't it? Some people get it, some people don't get it even after 60. So what is the mechanism of this? We see there's an increase in the growth of transitional zone cells, but how does it occur? What is the normal way? Other people have a normal size gland, like 15 to 20 grams is present in most of the men. Only a few men have a enlarged size, so their gland goes on increasing to the 40 grams, 60 grams, or even 90 grams. There are people with huge glands. What is the mechanism?
So,
Is there any hormonal reason for that?
androgen dependent glands, sir.
Very good. So which androgen? Which hormone causes the increase in the growth? Which is the androgenic hormone?
Testosterone.
Testosterone. Okay, there is always a. Do men have estrogen in their body?
No, sir.
No, absolutely
Yes.
no. All men also have estrogen. Women also have androgen. Okay, testosterone. So, but only thing, the dominance. Men have dominantly androgenic hormone testosterone, whereas women have the estrogen, which is their dominant hormone. Okay, that is why the features are little different. But both of us have, because they are basically made from which, what is the basic product from which are the so-called what do you call that basic substance from which it is made?
Steroid.
Cholesterol. Cholesterol is contained into steroid and then converted into glucocorticoids as well as this hormonal sex hormones. Okay, we study in the anatomy of your adrenal gland and adrenal layers. No? That's where you have to read all this. So the prostate actually has a majority have androgens. So they have this androgen causes a balance between the agonistic and antagonistic. So there is on one hand there is a cell proliferation, another hand there is a cell death which is called apoptosis. So if this is in balance, as many number of cells are produced, if number of cells dying also is equal, then patient will have a normal prostate. A normal person will have a normal prostate. On the contrary, if there is a tilt where the cell proliferation happens more and cell death happens less, then what happens? Number of cells growing or increasing, which causes the proliferation of the prostate. Okay, and that is what is the importance of knowing this.
Treatment we can give.
Medical management can be done by blocking the androgenic hormone or the testosterone. Okay, dihydrotestosterone is the one which makes the prostate cells grow. So if you block the action of that, you can to some extent control the increase in the size. So all patients who come with symptoms of enlarged prostate, immediately the urologist will not ask him to undergo TURP. They will advise them to take medications initially by oral route, and some patients do get relief because the growth is further, prevention of growth occurs, and prostatic size also shrinks to some extent, and they get a normal urination or somewhat compromised or better urination than before. So initially they will always try oral medications which can act on this particular level, and that is the reason why we have to know about this cell proliferation to apoptosis or cell death imbalance that happens in that. So BHP is a imbalance of hormones, age-related changes in the prostate, and loss of balance between cell growth and cell death, leading to the enlargement. And the risk factors are aging. There may be a family history. It also runs in the family as a genetic problem. And obese people also develop lifestyle factors like sedentary life. All these things lead to this particular BHP problem. And the shift in the balance between testosterone and estrogen, along with higher dihydrotestosterone levels, promote the prostatic cell growth. Now, what is the blood supply of the prostate? Already we have seen that, but you have to be very specific in the branches. So, three branches of internal iliac artery, namely the inferior vesicle, inferior rectal, and pudendal. These are the three branches of internal iliac artery which supply. There is no direct vessel called prostatic vessel. Please remember that. Because of the multiple supply from various levels, that is why the prostate is very vascular and richly, because of the rich blood supply, it can cause more bleeding. And venous drainage is through the prostatic plexus of veins, which drain again into internal iliac vein, and through this vein only it will go and join the inferior vena cava, and the blood, the irrigating fluid will join the systemic circulation, and that is how the fluid overload happens. Now, what is the nerve supply of prostate and its significance? You just mentioned inferior hypogastric plexus, but could it be answered in a better way?
Sympathetic and parasympathetic supply.
There is no sensory.
Sensory is carried by the
carried by
the T10 to
pudendal nerve. Okay, there is a sensitivity also. So, what is the role of sympathetic? What is the role of parasympathetic nerve supply to the prostate? Why it has got such a supply of autonomic system, like sensory, sympathetic and parasympathetic? Now receives sympathetic, parasympathetic, sensory from inferior hypogastric plexus. Okay, that is one answer that you can give. But the role of each one, sympathetic originates from L1, L2 spinal nerves, and this is the one which causes the smooth muscle contraction, which is crucial for ejaculation. As I said earlier, it has a fibromuscular capsule or portion which causes the ejaculation, and that is done by the sympathetic system. Parasympathetic stimulates the glandular activity, that is the milky fluid which contributes to 30% of the semen volume, that is stimulated by the parasympathetic. Okay, and there are also cavernous nerves which are run along the prostate sides on the posterolateral side, but they do not actually supply the prostate gland, but they are the ones which are responsible for erection in the male. Uh, uh, but because the importance of this is when the surgeon is careless and he destroys or damages these nervous systems, then it may not actually cause any pain, but the patient will lose the potency for erection postoperatively. So the loss of erection will happen if the cavernous nerves are affected, and if the parasympathetic nerves are affected, especially if the TURP is done for younger individuals and they damage these nerves, these are the problems they can undergo. Loss of ejaculation. Sometimes they go in for what is called retrograde ejaculation. The semen may not be ejected out, it will go back into the bladder. And this glandular secretion also will be affected. So these are the three important things that you have to know about the prostatic nerve supply and their significance. Now, what are the clinical features of BHP? You mentioned about the various possible problems of voiding. So the problems are mainly due to the storage. The storage means there is always some urine left out. Patient cannot empty the bladder completely. Okay, what is that urine called?
Residual urine.
Residual urine. And what is the volume which is significant?
More than 50 ml, sir.
More than 60. Okay, 50 to 60. 60 is ideal. So 60 ml indicates that there is an obstruction. And what are all the different ways of avoiding difficulty patient will have? American Urology Association, AUA, has given some descriptions, 7 descriptions of the various types of voiding difficulty. And you have to give a scoring on that. Are you aware of that?
No, sir.
No. Okay. So the American Urological Association symptom score, there is one score. So patient may have any of the following. He may have hesitancy or hematuria. He may have intermittence or incomplete sense of voiding. The stream will gradually become thinner and thinner, and the frequency will be there. Patient will have to use the restroom quite often, and sometimes they have to go urgently, otherwise they will have incontinence and spill it on their clothes. They may have nocturia, wake up several times, and they may have dribbling. So these are the 7 things that are being described: hesitancy, intermittence or incomplete, thinner stream, frequency, urgency, nocturia, and dribbling. So I made a mnemonic out of it for it, which is called HISFUND. You can see H for hesitancy, I for intermittence, stream becoming thinner, frequency, urgency, nocturia, dribbling. So if you take all the first letters, it becomes a mnemonic to remember as HISFUND, HISFUND. So what are the other ways of presentation of BHP? Apart from this voiding difficulty, what are the problems that can happen due to the storage or excessive accumulation of not voiding completely?
UTI system.
Fantastic. Many acute retention, recurrent UTI, patient may have anorexia, fatigue, azotemia, and this back pressure can in the long run lead to renal failure also. Okay, very good. And what are the other things that patient can develop because of straining? Because of the thin stream and obstruction, usually these patients will have a straining habit. They try to increase their intra-abdominal pressure to void. That makes it worse. But over a period of time, they are able to overcome that obstruction, and if they strain more, they are able to void better. So, but what are the other problems that can happen because of the straining, which leads to intra-abdominal pressure increase?
Into hernia, sir.
They can develop hernia or hemorrhoids. Okay, so the patient can develop hernia or hemorrhoid due to straining to pass urine. And sometimes what happens, they come with this problem mainly. They come for bleeding piles or hernia, And only when you question them properly, they say yes, they have difficulty in urine, and they are able to overcome that by increasing their intra-abdominal pressure. So the primary complaint sometimes may be a hernia or hemorrhoids. So in all patients with hernia or hemorrhoids in the elderly, make sure that there is no enlarged prostate. Okay. Then proper questioning will only reveal this primary problem of BHP, resulting this is a secondary effect because of the straining. What is the medical management of BHP and its significance to anesthesia? What are all the various ways by which the urologists treat the BHP initially by pharmacological methods?
Alpha block.
Alpha blockers, very good. What are the types of alpha blockers they use? Any beta blocker or alpha blocker can be classified as non-selective and selective. Okay. Earlier, propranolol, is it a non-selective or a selective beta blocker?
Non-selective.
Non-selective. It acts on so many other systems also apart from the heart. Okay. So because of that only, they identified a beta blocker which will selectively act only on the heart, like metoprolol, atenolol, sotoprolol. All these things came later to selectively act on the heart. Similarly, alpha blocker, initially it was non-selective. What is the drug which was first introduced as a non-selective alpha blocker, which is also used in cases of pheochromocytoma?
Pentolamine.
Pentolamine, is it an alpha blocker? Phenoxybenzamine, okay? Phenoxybenzamine. Then you had, so what does this alpha blocker do?
It relaxes the muscle.
Very good. Relaxes the smooth muscles. So it blocks the sympathetic activity, which we saw. That is a reason why I asked about the nerve supply, sympathetic, parasympathetic, and the cavernous sinus. What are their roles? So they block the sympathetic activity to produce relaxation of the smooth muscle. So some amount of enlargement of the urethra will happen because the prostate is now relaxing. It is not tightly trying to push and constrict the urethra. It is now relaxing. Okay. So that is the first line of treatment, alpha blocker. Then what other things can be tried? What are all the second? There are three groups of drugs which are used.
Phosphodiesterase.
Phosphodiesterase inhibitors. Fantastic. Tadalafil or sildenafil. So when are they indicated? Is it given as a routine?
When the
first line of treatment is the alpha blocker. That is what will be prescribed by most of the urologists. When do they use phosphodiesterase inhibitors?
Erectile dysfunction.
If there is a ED, erectile dysfunction is also associated with BHP, then you can get both relieved by the phosphodiesterase. Which group of phosphodiesterase is inhibited? Which other phosphodiesterase inhibitor you use for the respiratory tract problems?
Pulmonary hypertension, we give phosphodiesterase 3 inhibitors.
Derifilin also is a phosphodiesterase inhibitor. Okay, but this phosphodiesterase, which class or group?
Phosphodiesterase
used for 5. Phosphodiesterase 5 is used. Inhibitor. Okay, so this is what you have to. That is the second. What is the third?
Anti-androgens.
Anti-androgen. More specifically,
5-alpha reductase.
5-hydroxy testosterone. I showed you the slide. That is the one which causes the cell growth. So by blocking that, so that is what is called the 5-hydroxy testosterone reductase inhibitor. This is the one which converts. Okay, so these are the and commonly used drugs are tamsulosin and the other groups. So the drugs that relax the smooth muscle, the prostate, urethra, and urinary bladder, they are called alpha 1A type receptor blockers, and they are classified into non-selective, which is phenoxybenzamin, selective, short-acting. That is selective is again classified into short-acting drugs like prazosin, alfuzosin, and doramin. And long-acting can be terasozin, doxazozin, sustained release alfuzosin. Why? What is the importance of this terasozin and doxazozin? What other action apart from relaxing the smooth muscle these alpha blockers can produce? Where else are they used?
Hypertensive. It's used as
It is used as an
antihypertensive.
antihypertensive also. Okay. So these patient, if supposing the BHP patient is a normotensive, initially when you prescribe this drug to relax the smooth muscles in the prostate, he may feel hypotensive and he may get a postural hypertension. Okay. So you have to warn that patient, and these patients when they come for surgery, if you give a spinal, they may have a very acute hypotension. So that is the reason why we have to know whether they are on any of these drugs. And the partial subtype of that is tamsulosin and silodosin. And phosphodiesterase 5 inhibitors are tadalafil and sildenafil. And 5-alpha reductase are finasteride and dutasteride. Okay. So this drug block conversion of testosterone to dihydroxyl testosterone, and they also reduce the prostate specific antigen by 50%. And they inhibit the initial growth of prostate by increasing the apoptosis or cell death and involution. Okay. So these are the three groups of drugs that are used, and this is not very commonly used. As I said, it is more indicated when there is a erectile dysfunction also. But other two drugs, the alpha blockers and this 5-alpha reductase, they are available as combination drugs also. It may be tamsulosin D, where they add dutasteride, okay, or a silodosin finasteride combination. These are available. So that is the important pharmacological knowledge you should have. And what is the importance of this drug in ophthalmology? Do the anti-BHP drugs have any relationship to ophthalmology? Okay, find out that homework for you. How to evaluate the patient regarding comorbidities? Now this patient has DM, hypertension, and pacemaker insertion. So what are all the questions or history you would like to ask in this patient to evaluate their comorbidities? One by one. That is DM, hypertension, and the need for pacemaking.
For diabetic patient, we'll ask for how long he's been diabetic, whether he is under oral hypoglycemic drugs or under insulin. Is it he is on regular follow-up about his HbA1c under control or not under control, sir? He's having any microangiopathies or macroangiopathies, end organ failure. These things we have to follow.
Any autonomic neuropathy has to be good.
Fantastic, very good. Okay, so that is about diabetes. What about hypertension?
So same, the duration of hypertension have to be is on any antihypertensives and whether under control or not. And is patient
We've been on regular follow-up.
Regular follow-up.
Has their drugs been changed? Okay, these are all the questions that you have to ask. Okay, so the geriatric assessment, what are all the things you, first thing we said that the challenge is the geriatric patient. So as a geriatric patient, what are all the things that you will like to ask the patient? Up to 70-year-old person.
Regular functional capacity, sir.
Fantastic. Is there any other name for that? Functional capacity, the old age? What is ADL?
Activities of daily living.
Activities of daily living. Very good. So that is the first and foremost thing you must ask any elderly person. Are you able to carry out your day-to-day routine? Are you able to have a bath by yourself? Are you able to go to the restroom by yourself? Are you able to dress up yourself? Are you able to eat yourself by yourself? Okay. So that is activities of daily living, whether he is able to do. Then you ask for functional effort. How long you can walk? Are you able to walk only in the level surface, or can you climb upstairs? Okay, that all comes under the functional effort tolerance. Whereas the activities of daily living or the day-to-day activities everyone has to do. Okay? Right. So that is the first thing you ask. Then what are the things you should ask in the elderly patients? Any geriatric patient coming for surgery. If you ask about the joint mobility, what is TUG test in the elderly? TUG, TUG test. What is the expansion for the TUG? Where else you do the TUG test?
Cylinders that in
Theater, do you do a
machine.
TUG test? The
Anesthesia.
OT? Where do you do that? How do you get your gas supply in your OT?
Pipelines.
Pipeline. So how the pipeline is inserted into the outlet, you pull that and see whether it is fitted properly, isn't it? Securely. That is called also TUG test. Okay, to see. Otherwise, some new theater boy may not have fixed it properly, and you just pull it, it will come off. But you need to have that unscrewing mechanism to remove that. So that is also a TUG test. But in the elderly, the TUG test is called timed up and go test. How a person is able to get up from sitting position to erect position, how much time he takes, whether he requires any help to hold on to something or somebody to lift him up with one hand. That is also called the TUG test. It is the assessment of his mobility. Okay, as age advances, patients find it difficult to get up from sitting position, even in a chair. Okay, that is the TUG test will tell you. So, always we must first see whether the chronological and biological age are equal or different. Because sometimes, chronologically a person may say I am 85 years old, but he may be playing tennis every day, he will be going for swimming, he will be active, he will be cycling, and he may be able to climb stairs faster than a young person. So biologically they are still young. So always assess whether they are biological and chronological age are same or different. Then see for the activities of daily living. Then ask for the cognitive abilities, whether they are able to remember things, whether they are able to recall older incidents, or whether they are able to identify persons in space, etc. Then for musculoskeletal, you can do the TUG test, and any previous joint surgeries and use of aids like spectacles or hearing aid or dentures, or chronic use of some of them say unless I take 0.25 Alprax every day I don't get sleep. So I have been using it for 10 years, 15 years now. So without that I don't sleep. Similarly, some of them may be using laxatives for constipation, and some of them may be using NSAIDs, and some ability to lie on the back at least for 1 hour. That also is a very important history that you should ask regarding the geriatric age assessment. Then with regard to DM and hypertension, the duration, how it was detected. This is common to both. Initial treatment prescribed for DM, sometimes, they may advise only lifestyle modification, cut down, reduce stress, all lifestyle modifications which are initially prescribed, and only if that you prescribe drug. Then how the patient adheres to the medications prescribed, what are the periodic monitoring, whether they get a blood sample done by the lab or home glucose monitoring with a glucometer at home itself. Similarly, patients with hypertension may monitor their BP at a Omron machine is available in every house, and everybody is able to check their OP and whether there was any change in medications and whether there are obvious microvascular complications like a gangrene toe which has been amputated or a retinopathy which has been treated with a laser treatment. So, and whether they have been diagnosed with any renal impairment with a raised creatinine or microalbumin. So all these things should be questioned. And with regard to the pacemaker, you can ask or what is indicated and what history of that. Of course, later on we can do the interrogation and find out. So this is how you answer the question of how to evaluate the patient, and this in your day-to-day practice also. In future, when you get a patient, elderly patient with comorbidity, you can follow this pattern so that you won't miss any details from this patient. Now, what are the indications and what are the types of surgery done for BHP? When do the urologist advise surgery for BHP?
Failure of medical management.
Fantastic, very good, excellent.
Patient has a recurrent UTI.
Okay.
The patient
Supposing a patient comes with an acute retention, the urologist manages somehow to pass the catheter, and they do a trial removal. Again, patient goes in for obstruction. Again, they pass the catheter. Is it indication for TURP? Yes. Whenever a person cannot live forever with a catheter unless he has been one particular person in the olden days in the political history. If you see a person had been living with a catheter until his last life, you know who is that? Okay, let us not discuss politics here because it's been recorded. So indicated medical management fails to relieve the symptoms, or when patient comes with an enlarged prostate, severe symptoms, acute retention, and on catheter for a long period, which may cause more problems. And what was the older method? It was open prostatectomy, where they used to make an incision in the lower abdomen, open the bladder, and do what is called enucleation of the prostate. That was the older surgical method, which was done in the open method during our postgraduate days. That was the only treatment available because TURP had not come in a big way. So now it is rarely done. The current method is TURP done with an instrument called resectoscope. Are there any other alternative for this? Less invasive. Laser is also done with the resectoscope insertion only. Instead of cutting, they use the laser beam. But more less invasive methods, they are called transurethral needle ablation, TUNA, and also TUMT, transurethral microwave thermotherapy, and also prostatic. Instead of cutting with the electrical current, they can use the oleum laser enucleation of prostate, or what is called the HOLAP, oleum laser ablation of prostate, or photovaporization of prostate. So these are all considered as lesser invasive and less stressful operations compared to TURP, which is done at the resectoscope. Why I have mentioned this? Any reason? Is it just to show off my knowledge or make you know that there are other treatments are available, or has any relevance to this particular case scenario we have?
The patient has
in this case, supposing this patient has a very severe problem in the cardiac, then these will be the options. Okay, instead of TURP, they can go for. Of course, the question here has been asked as management of TURP, but you should know that in very severe cardiac cripple patients, the other options are, these are the options which are much more safer compared to TURP. Okay, that is the reason why it has been mentioned. Now, what are the pre-op investigations needed in these cases?
CBC, chest X-ray,
In blood investigation,
ECG,
sir.
echo,
Routine blood investigation, CBC, coagulation.
HB,
Yeah.
HbA1c, serum
Okay.
electrolytes,
Very
urine
good.
protein, ECG, echocardiogram, and chest X-ray, sir,
chest X-ray.
to identify the position of the pacemaker, to analyze the cardiac status of the patient, sir.
Very good. So, routine pre-op, CBC, urea creatinine, blood grouping and cross-matching is a very important investigation. Why?
If there is a
Sometimes bleeding,
If there is a hemorrhage, you need to sometimes transfuse blood
transfusion.
also. So, all TURP patients should have their blood grouping and reservation done. You need not bring the blood to the table, but you should reserve adequate blood and urine routine for any current infection. So if there is a urinary infection present, can I go ahead and do the surgery?
no, sir, we have to
treated acutely.
Why do you have to control that infection?
the patient will end up in septicemia post-operatively.
Fantastic. It will, because the urine will also get absorbed along with the irrigating fluid into the system. So it will produce what is called urosepsis. Patient will go into septicemia because of the driving of this contaminated urine into the bloodstream. So patient may develop what is called post-op urosepsis, which is a very, very grave complication. Okay. So that is the reason why you should have the urine should be culture should be negative, no organisms grown. And what is the importance of electrolytes? Specifically, I have mentioned specifically sodium.
TURP syndrome, sir. We have to know the pre-op sodium level.
Very good. So you can find out whether the patient is in real TURP syndrome by analyzing or estimating the sodium after TURP syndrome. Then only you know whether it was normal before and whether it has now reduced and hyponatremia has set in. For that, it is a very important investigation. You should look into the electrolyte value and document whether the sodium is normal or not before surgery. Then with regard to CVS and hypertension, as you rightly said, X-ray, ECG, lipid profile, and patients with severe cardiac symptoms or patients who now on pacemaker, we have to make sure there is no acute injury like with the elevation of cardiac markers of TROP-I and BNP. And for DM, you can ask for fasting PP sugar, HbA1c. Our patients who are on insulin, better markers will be pre-dinner and pre-lunch sugars, which will give an indication whether the DM is under control or not. And all DM patients should have a microalbumin estimation done to rule out any early nephropathy. And clinical assessment for peripheral neuropathy is very, very important, because supposing patient already has a sensory neuropathy in the limbs, and you give a spinal, and it gets a little aggravated post-operatively, he may complain or he may blame the spinal for worsening of the sensory neuropathy. So in all diabetic patients, make sure you document the presence or absence of peripheral neuropathy. And with regard to pacemaker, interrogation for battery life, lead placement, availability of magnet to convert it to asynchronous mode, and always you should have an emergency transvenous pacing equipment ready whenever you deal with pacemaker patient for any surgery. What are the pre-op instructions you will give? Routine starvation before surgery, elective surgery. So what is the problem in starving a diabetes patient? He can go in for hypoglycemia, isn't it? So you are always worried about hypo rather than hyper, isn't it? So you should, the instruction should be adjustment of medications first for hypertension and DM and cardiac conditions, instructions regarding starvation based on the surgery, and dose adjustment of oral hypoglycemic drugs. Supposing it is a morning surgery, surgery is done at 6 a.m. and patient is usually taking insulin at before breakfast. What will you advise?
We should
You have been
withhold
starving
insulin.
for 6 hours.
We should withhold insulin.
They should withhold insulin. Similarly, supposing the surgery is in the afternoon and you say you can have a light breakfast at 8 o'clock. Surgery is only at 2 p.m. or 3 p.m. So what will you advise?
Based on the pre-breakfast CBG values, will give
Based on
the
patient is allowed to take some breakfast.
yes, sir.
So what adjustment you have to make with the oral hypoglycemic agents or insulin? And you have to write that instruction in your pre-op assessment always. If it is metformin, will you allow that to go?
Yes, sir.
Huh?
Can be taken.
Metformin can be stopped. Okay. And if he is taking insulin only, supposing he is taking 10 units of insulin, will you allow the all 10 units to be taken after breakfast or will you cut it short? Because he is going to be starving for the next 6 hours. Always make it 50%. Okay. Reduce the insulin also to 50% so that he will not go into hypoglycemia within that starvation time. And always have the blood sugar checked 2 hours after the start of the starvation period. And if there is a blood sugar less than 100 milligram, what should be the advice? This is the answer here. Instructions for glucose administration to prevent hypoglycemia. What is that instruction you will give? Supposing blood sugar after 2 hours of starting starvation, NPO, is 80 milligrams, what will you do?
Will give dextrose. DNS will start with maintenance fluid as
What is the volume that you will give? What preparation you will give? Will you give 5% dextrose or will you give 5% dextrose saline? How many ml per hour you will give? That is the way thing that you have to know. This is practically also important. So any diabetic patient, if the blood sugar is less than 100 milligram after 2 hours of NPO, start them on 75 ml of dextrose saline. Okay. If he is a hypertensive, go for plain 5% dextrose alone. 75 ml per hour is the IV fluid regimen that you have to follow. And after 2 hours, again check. If it is more than 100, continue at the rate of 75 ml. If it has become less than that, increase it to 100 ml per hour. Okay. So these are all practical tips that you should know to avoid hypoglycemia in these patients. Okay? So this is a very important pre-op instruction. And what are the techniques of anesthesia that can be employed for TURP surgery?
we always prefer regional, sir. Spinal.
Most preferred technique is
Spinal. Regional.
what type of spinal? You say spinal, does it have it's the complete answer? You should always say single shot spinal. Okay? Because there is another technique called continuous spinal. Of course, which is not practiced nowadays, but always you must in the exam answer in a qualifying manner. Single shot spinal is the preferred technique of anesthesia. Supposing patient refuses because he says he had already a hernia surgery done under spinal and he is still experiencing back pain. So I don't want spinal. That is a specific request from the patient. Then what else you can do? What is the other option?
General anesthesia, sir.
Huh?
General anesthesia.
General anesthesia. Yeah. Anesthesia is very easy because we have only two, regional or general. Okay, so if the examiner says what regional is not acceptable, then you have to go for general. And in general, what type of anesthesia you will give? You give it with endotracheal tube intubation, mask ventilation, or LMA?
Will be endotracheal intubation.
Only endotracheal. Why endotracheal? Why can't you do it under LMA? Is it possible to do it under LMA? Earlier, when LMA was introduced, who introduced LMA?
Archie
Archie Brain. Very good. Which country he belongs to? He's a Britisher. Okay, United Kingdom. He designed it as early as 1980s. Okay, he designed that laryngeal mask airway as an alternative to endotracheal intubation, and it became very popular. So when his initial classic LMA was there, it did not have a drainage port for any regurgitated material from the stomach. So at that time, they thought it is not ideal to use LMA classic by designed by Archie Brain, because when you put lithotomy, what will happen to the intra-abdominal pressure?
It will be increased.
It will increase. So there is a possibility of the stomach contents regurgitating into the pharynx and getting aspirated. But with the current second and third generation LMAs, which have a drainage port, is it safe to use them, like ProSeal or other newer, like what is called iGel third generation LMAs? Okay, Basca, mask, all these things are much safer. So they have now accepted that you can use the second and third generation LMA also for maintaining the airway to do either controlled ventilation or spontaneous ventilation. So that is also another option. So RA is the most preferred. What is the reason? Because you can identify the TURP syndrome.
Conscious level of
at
the
patient. Patient is awake, so you can easily find out whether he is. So what is the earliest symptom of TURP syndrome?
The patient will be
earliest.
The patient will be restless, nausea.
Before that also. Even before the patient becomes, that is all advanced stage. Patient has started absorbing a lot of fluid, and it has started affecting the cerebral system. So patient becomes restless, nausea, vomiting. When it comes, it means it is an advanced stage. But what parameter will tell you that he is likely to go into TURP syndrome when a patient is under spinal anesthesia specifically? What is the normal response of an elderly patient soon after you give a spinal? What will happen to his blood pressure and pulse rate?
There would be profound hypotension, sir. And
profound hypotension. Okay. So does it happen in every patient?
For elderly person, the blood pressure will be drastically reduced, sir.
So are you seeing that drastic fall in every TURP that you are giving anesthesia in your hospital?
No, sir.
No, sir. Then why do you say that? It means you are adjusting the volume and you are making the position in such a way that you don't allow such a drastic fall, especially in the elderly, to happen, isn't it?
Yes, sir.
So, but there will be some amount of hypotension. No, not a drastic fall as you described, but every patient is likely to have a mild form or moderate form of hypotension after spinal, isn't it?
Yes, sir.
And is it preferable to have a light, mild hypotension for TURP surgery?
Yes, sir. The bleeding.
Does it help the surgeon? Will he be able to have a better field without bleeding if there is a mild hypotension?
Yes, sir.
Yes. So the routine behavior of a patient after spinal will be a moderate to mild to moderate hypotension, and also to compensate there will be a slight increase in the pulse rate. Okay, or the pulse rate also may go down depending upon the level of the block. Okay, so first half an hour or so, unless you give the fluid rapidly, patient is likely to exhibit, majority of the patients will have a mild hypotension, and if it becomes very severe like 80 by 40 or 50, then you immediately administer vasopressor to bring it back to normal so that he doesn't suffer from the effects of hypotension, isn't it? This is the way you have been taught, isn't it? Yes or no?
Yes, sir.
Right. So, on the contrary, a patient, for example, let me say in numbers for you to understand better. You start with a BP of 140/80 and you give a spinal. What is the position you adopt for giving spinal in your hospital?
And sitting position, sir.
Sitting position is preferred because that will prevent the level going up too high, and you choose the lowest possible space because you need a block only up to T12 maximum. Why you require a block up to T12? Thoracic 12 segment. Because you said the sympathetic supply is from L1, L2. I showed it in the earlier slide.
Yes, sir.
And the parasympathetic is from S2 to S4. Why do you require a block up to T12? What is the nerve supply to bladder? It is from T12 to L1. Okay. So when the bladder gets distended by the irrigating fluid, if the block is not up to T12, patient will experience the bladder discomfort. Okay, distension will cause some amount of discomfort and patient will complain of that as a pain. That is the reason why you need to have a block up to thoracic segment 12. And if this produces, say, from 140/80, BP comes down to 110/60. How do you treat that? Would you require treatment or do you ignore it and maintain it at the same level?
For the spinal
Will you
level
rush
is
and do
actually
it in this case to bring up the BP to say 140/80 again?
for patients, sir, or a normal patients.
This question, this case scenario only I'm discussing now. I'm not asking about the routine geriatric patient coming for TKR or hip replacement. I'm not asking that.
Since they are using irrigating fluids, sir, there would be more absorption. So we don't rush fluid in patients, sir.
Excellent. So TURP patient, resuscitation of hypotension is done preferably with a vasopressor and not with fluids. That is a very important practical point all of you should remember. Okay. So giving a small dose of 3 to 6 milligrams of ephedrine will be sufficient rather than rushing in 500 to 1000 ml of IV fluids. That is a very important point. Otherwise, invariably you will land up with overloading. So when you are not giving fluids and if the patient on his own starts developing a high BP from 140/80 after 15-20 minutes of resection, if the BP goes up to 150/100 and the pulse rate starts dropping to say from 70 to 60/50, that is the earliest indication that volume overload is occurring, because now the blood volume is increased, the stretch receptors in the atrium will sense that, and there will be a reflex bradycardia and hypertension will happen. That is the stage you should pick up any TURP syndrome. That is the reason why a close monitoring is very, very important to avoid TURP syndrome. And from next stage onwards, when you do that, if you gradually, sincerely observe and record or document their blood pressure, you will find this change occurring in patients who develop TURP syndrome at the earliest. After this only, they will go in for restlessness, nausea, vomiting, all that will happen after this in the first change in the hemodynamic conditions. You will develop a hypertension and bradycardia. Right. So that is all the details I want to give. So types of RA are single shot or epidural or even caudal anesthesia is safe in many people. But only thing, when you give caudal, the level of block may not go up to T12. So you should tell the surgeon not to use continuous irrigation for a long time and deflate the bladder on and off without distending it too much. And combined spinal epidural and pudendal nerve blocks also have been done for TURP surgery. And always contraindicated, you go for regular IV induction, and then endotracheal intubation or second, third generation LMA with alienation anesthesia with or without controlled ventilation can be done. What are the important monitors that you will use?
Standard
Regular
AEC
monitors plus temperature monitoring is very, very important. Why? Because the irrigating fluid, is it a room
it's
temperature
normal.
or is it warm?
At room temperature, it may cause
So that may reflect the patient core temperature. Okay, and also monitor his consciousness and mentation if the patient is under GA. The common question they may ask you is, supposing the patient is under GA, how will you identify TURP syndrome? The patient is under spinal, you can always see whether the patient behaves in an irritated way, restlessness, whether he is pulling out at the IV line, and whether he is complaining of nausea, vomiting. All that can be easily done in a regional anesthesia. But if it is under general anesthesia, again make it a homework question. Okay?
Sudden hypertension, hypertension, tachycardia, or reversal bradycardia.
That can be due to lighter plane of anesthesia, pain, or carbon dioxide accumulation because of soda lime. That is the common way the examiners will ask you. So these things also will produce tachycardia, hypertension. Right, you find out the answer. Okay. What are the intra-op complications? How do they are managed in TURP surgery?
Hypotension, bradycardia, the patient may develop, if the volume is overloaded, they may end up in pulmonary edema.
Okay.
And
already we have noted one, we discussed one complication, perforation of bladder or capsule. Okay. So
yes.
The common complications are hypotension, TURP syndrome, hemorrhage. Bleeding is a very important complication. Perforation, hypothermia and shivering, bacteremia and sepsis. Complications of positioning. Patient may have problems in the lithotomy position, and the initial erection of the penis. As soon as the spinal is given, before they start introducing the resuscitascope, sometimes you find that the penile elongation is so much that introduction of the resuscitascope itself is very difficult. And lastly, glycine toxicity, which may be occurring because of the usage of glycine as a irrigating fluid. So these are all the drop complications. And their management, hypertension, better to manage with vasopressors rather than IV fluids. And the hypothermia management by preventing hypothermia occurring by using warming devices, ambient temperature adjustment, and warming the IV fluids, etc. And bacteremia is prevented by appropriate initial antibiotics before the start of the surgery. And the positioning problem, careful lithotomy position, always lift both the legs together. Some hospitals, the theatre boys do not know this. They will lift one leg and then the other leg. This is the reason for the sciatic nerve stretching and damage post-operatively. There have been cases where patients have developed foot drop because of this problem. So positioning is very, very important, and care of the pressure points like the sacrum and elbow, all these things have to be taken care of. And penial erection can be treated with small doses of ketamine or dexmed or even beta finis. All these things have been tried. And what are the problems of glycine toxicity and how is it managed? What is glycine?
Glycine. Inhibitory neurotransmitter.
Inhibitory neurotransmitter, yes, it's a major inhibitory neurotransmitter in CNS and retina. Okay. So what will happen if it is accumulating because of the use of glycine is the commonest fluid we are using, isn't it, for TURP resection nowadays? Is it the same in MIOT also or different?
We are using saline, sir.
You are using saline. Oh, okay. So glycine is not used.
Yes, sir.
Okay, right. So glycine toxicity may cause nausea, headache, eyes weakness, and visual disturbance, and even transient blindness, and may also directly depress the myocardium. And but paradoxically, it stimulates the NMDA receptor, which may lead to seizures. And the liver and kidneys metabolize glycine by oxidative deamination, and the end products are glyoxylic acid and ammonia. So this accumulation of ammonia may cause cerebral depression. And its redistribution half-life is 6 minutes, but terminal half-life is about 40 minutes to several hours. And the role of hyperammonemia in TURP syndrome remains unclear, even though ammonia is a cerebral depressant. And magnesium levels also go down because of the dilution, and that may be, aggravating the seizure activity. So treatment with magnesium will lower the seizure if other anti-epileptic drugs are not acting sufficiently to control the seizures. So it is treated as just like your TURP syndrome. So there will be fluid overload because of the absorption. So always give diuretic. For seizure, you can use benzodiazepam or other anti-epileptic, and magnesium if these drugs are not able to control. And then hyponatremia also will happen. So you can start hypertonic saline. There is a neurological manifestation. And you must always measure the osmolality to, and if it is less than 260, try to raise it by sodium, and given at the rate of 10 to 12 millimoles per 24 hours. Very severe cases may require renal replacement therapy, and treat acute pulmonary edema and dyspepsia as you regularly do that. And patients may develop hypocalcemia also, so better to replace calcium. And TURP syndrome. What are all the features of TURP syndrome? TURP syndrome.
CNS manifestation, disorientation.
System wise, very good. You have to do it in the system wise thing. So it is essentially a clinical diagnosis because of excessive absorption of irrigating fluid. So acute changes in intravascular volume will cause plasma solid dilution, and osmolality will also change, and it will be the effect of irrigating fluid or due to glycine. And so initially I said patient may develop hypertension and bradycardia because of the fluid overload. But what will be the ultimate effect after more fluid has been absorbed? What are the parameter changes that will happen in the cardiovascular system or hemodynamic status? Will it continue to remain as hypertension and bradycardia, or will it go in for hypotension and so it may present as early as 15 minutes after start of surgery, and it may occur up to 24 hours after surgery. So it is not necessary that TURP syndrome should occur only on the table. It can happen anytime up to 24 hours, especially if the post-op irrigation is continued to prevent clot retention inside the bladder. This is a possibility that it can happen anytime. And the irrigation of fluid absorbed at the rate between 10 to 30 ml per minute of operating time. So this is how the volume increases. Now the rapid absorption of large fluid can cause initially hypertension with reflex bradycardia and precipitate acute cardiac failure and pulmonary edema. But later on, what will happen? this rapid equilibration of the hypotonic fluid with extracellular fluid compartment may then cause hypotension in association with intravascular hypovolemia. So the hypotension and hypovolemia will be aggravated by the sympathetic block produced by spinal anesthesia. This is the secondary phase at the end of operation, often the first sign of TURP syndrome. So early stages, you will have hypertension, bradycardia. Late stages of TURP syndrome, you will have hypotension and hypovolemia. Okay? So acute hyponatremia also will be produced by the initial dilution and also later by using your diuretic, which causes loss of sodium. So the two reasons for hyponatremia are initially by dilution, later by treatment with Lasix to reduce the volume, you lose sodium also. So serum sodium concentration should always be measured with serum osmolality. Why? What is the normal serum osmolality?
200
280 to 290. Okay, 280 to 290 milliosmoles per liter is the serum osmolality normal value. So sodium with a normal osmolality, supposing there is a hyponatremia, what is the normal sodium value?
130
130 to 145 milliequivalents. Supposing it is 120 and patient osmolality is normal, 280. Does it require treatment?
If the patient is symptomatic,
Asymptomatic, not symptomatic, asymptomatic with a normal osmolality, hyponatremia need not be treated. On the contrary, if patient is symptomatic, then you treat it. Okay, the osmolality is normal. There is no intervention is recommended to correct the sodium. The patient is asymptomatic. Right? Dilutional hyponatremia may prolong the action of ND blockers also. If you are giving GA and you are using controlled ventilation with a muscle relaxant, and intraoperatively patient develops TURP syndrome, you have to send the blood sample to find out the sodium level, and if it is there is hyponatremia, that is the one confirmation for TURP syndrome, and also the action of neuromuscular blocking agent will get prolonged. And another ECG sign will be a QRS complex or T wave inversion will happen. Broadening of QRS complex and T wave inversion will happen. What are the manifestations of different levels of sodium? Will the sodium hyponatremia at all levels of sodium will be the same or it will be different? It's different at different levels. Okay, so
Yes,
this
sir.
is the chart you will have to see. At 120 milliequivalents from the normal 130 to 145, CNS changes, confusion and restlessness if the patient is conscious and undergoing surgery and regional. Serious changes, hypotension and bradycardia. ECG changes, white QRS complex. At 115 milliequivalents, patient will become drowsy, will have nausea, there will be cardiac depression, there will be bradycardia with white QRS, elevated ST signal. If it is 110, patient may go in for a seizure activity or coma, congestive heart failure, ventricular tachycardia or fibrillation can happen. So the ECG changes also is a very important monitoring which requires to identify TURP syndrome. What is the treatment?
for symptomatic patient,
Symptomatic treatment. Yes. First, what is the answer you will have to give in the exam? How would you treat TURP syndrome? What is the first answer? Huh?
Stop the
this
surgery.
medicating fluids.
Or adequate ABC, airway breathing circulation.
ABC airway. Who said that? Bindhu.
Ranjani,
Ranjit. Okay, fantastic. That is the first answer. ABC survey, airway, breathing, circulation. Okay, good. And if it is, what is the next step you do? Supposing
Because
patient is
Stop the
restless,
IV.
procedures, sir.
ask the surgeon to stop the surgery. Okay, surgery should be stopped, not abandoned completely, can be stopped. And IV fluids also to be stopped. Okay, then what is the next thing you do? Step by step
Diuretics
treatment.
can be given.
Huh?
Diuretics can be
Diuretic.
given.
Before giving diuretic, how will you prove that it is TURP syndrome? All
CM
these features
sodium
are only.
concentration. CM sodium
Send a sample
concentration.
for sodium estimation. Don't forget that at all. That is the only
Yes, sir.
thing which will save you in the court of law if there is any contention later on. So before giving Lasix, you must send a sample to the lab for assessment of sodium and osmolality. Both should be checked. Don't forget that. Let it be the lesson of your life. Okay. In case, unfortunately, if this happens, blood sample for sodium, osmolality, and hemoglobin should be sent. Then only bradycardia and hypotension should be treated with atropine, adrenergic drugs, and IV calcium if they are not responding to these two. Because hypocalcemia is also another important reason for the bradycardia and hypotension. And IV diazepam or torazepam to control seizures, or IV magnesium if the seizure continues, and then you go for Lasix also. So how to measure the volume of fluid absorbed during TURP? Is there any formula?
Pre-operative serum sodium divided by post-operative serum sodium into extracellular fluid levels. So initial minus.
Very good. So this pre-op sodium, that is why the sodium estimation in all TURP patients pre-operatively is very, very useful and important in case this complication happens. And post-op sodium, or the sodium at the time of suspicion of TURP, then multiplied by the extracellular fluid volume percentage of the body based on the patient's body weight. From this value, you subtract the extracellular fluid volume, then you get the volume of fluid absorbed. The other easier method is, in case of ml, you want to do weight of the patient multiplied by 0.6 and fall in serum sodium, that is the difference between pre and post-op, multiplied by 1000 divided by 155, another formula that you can use. What is the rule of 16 for TURP surgery and its significance?
Duration should not go more than 60 minutes. So.
Surgery duration 60 minutes, very good.
And absorption fluid also should not be more than
Absorption?
Absorption of the fluid.
That is not in your hands. Unless you have stopped the surgery at 60 minutes and you have not resected enough with it, can you prevent absorption? Duration 60 minutes is right. Anything else?
60 centimeters. 60 centimeters.
Height of the irrigation fluid not more than 60 centimeters. Very good. Second point. Then weight of the gland?
60. It should be less than 60 grams.
Less than 60 grams. Supposing patient had a 80-gram prostate and you want to reduce it to 20 gram, you can resect up to 60. On the contrary, the initial volume assessed by the ultrasound or other imaging techniques is 100 grams. And you cannot be going on resecting all the 80 grams to produce an adequate open passage. You have to say the patient that you will have to do it in 2 stages. The surgeon has to tell that beforehand to avoid excessive timing. Okay. So the resection time should be restricted to 60, weight of the gland resected 60 grams, height of irrigation fluid 60 centimeters. So following this rule will help in reducing the incidence of TURP syndrome. How to manage anemia or BAC, which are the very late complications of TURP syndrome, apart from the fluid overload.
It's mainly
acute anemia.
will transfuse
Packed red blood cells. As usual, for any anemia, you have to give PRBCs, packed
Transfusion.
red blood cells. For BAC, supposing wherever you puncture, patient is bleeding. There's a hematoma formation and they
provide FFPs.
FFP. So in case of DAC, fibrinogen 3 to 4 grams should be given intravenously, followed by heparin infusion of 2000 units bolus, and fresh frozen plasma and platelets may also be used depending on the coagulation profile. Okay. How to calculate the blood loss in TURP surgery? This is about fluid absorbed into the body. Is there a way to calculate the blood loss in TURP surgery?
From the irrigating fluid, calculate the hematocrit.
So the hematocrit of the irrigating fluid multiplied by the volume of irrigating fluid divided by the hematocrit of the patient before surgery is a simple formula to calculate the blood loss. Okay, and the formula, there is also another formula, that is the pre-op hematocrit minus the post-op hematocrit divided by the pre-op hematocrit multiplied by 0.0 into 1000. This is another formula that can be used. What are the features of an ideal irrigating fluid for TURP, irrigation fluid?
It should not contact current cell.
Very good.
And it should be
non-toxic,
transparent.
It should be isotonic.
First of all, surgeon should have a good visibility through the fluid. Okay, so he can see the dissecting thing, bleeder. Then only you can perform the surgery. So transparent, non-conductive, isotonic, sterile, and inexpensive. These are the 5 things which are required for an ideal irrigating fluid. What are the various irrigation fluids that are used? Apart, you are using saline, but majority of the urologists prefer glycine. What were the fluids used earlier? For some examiners are fond of using history, asking for the older things that were used. What was the oldest irrigating fluid?
Water.
Sterile water, not just water. It is sterile water was the first fluid that was used because it was non-conductive. But what was the problem with sterile water?
It's hypotonic, it reveals a hemolysis.
Hemolysis. When it gets absorbed, it is so much of hypotonic, it caused hemolysis. Okay, so distilled water, sorbitol, mannitol, glucose, urea, all these things have been used. But currently, people are using normal saline as well as glycine. So these are all the various features of the solution, their osmolality. But in practice, most of them, except mannitol, are all hypotonic. Okay? So even though even glycine is having a osmolality of only 220, your normal saline is very close to your body osmolality. So probably that is the reason why your surgeons are preferring that. And how to identify bladder perforation? We have already failure of return of irrigation fluid, distension of lower abdomen, patient complaining of shoulder pain. What are the post-op problems you can anticipate?
Clot retention, TURP syndrome,
Trigone irritation,
post-op
producing
cognitive dysfunction.
Very good. PVT, cognitive dysfunction. Now coming to the pacemaker and TURP, what are the problems? How to manage a patient with pacemaker for TURP? What are the precautions you have to take? Of course, we have briefly discussed that.
Yes, sir.
Why the pacemaker has been used, indication for the pacemaker.
So first, during management, it is essential to have a continuous ECG and pulse oximetry monitoring to indicate any beat-to-beat display for correlations with the to identify any artifacts or electrical disturbances. This is the first requirement. Okay. Of course, you will have these 2 monitors on all patients. So what type of pulse oximeter monitor you should use in these patients? Is it enough if you get a saturation value? With a plethysmograph. You should have a plethysmograph also present in the pulse oximetry. And the ECG monitor should be set at a diagnostic mode, not on the regular display mode. It should be able to diagnose any arrhythmias or any artifacts. So you set the ECG on a diagnostic mode so that the spacing spikes can be appreciated. And the use of bipolar cartridge instead of monopolar is preferred. And the electrosurgical receiving plate, that is the so-called plate, which is used to be positioned so that the current pathway does not pass through near the pacemaker. So, what is the distance you should have that plate or the electrode that is pasted? Or nowadays, they don't use the metal; they use a disposable which is slapped onto the thigh or abdomen, isn't it? Blue color thing. Most of you would have seen. So that is the earth plate or the earth grounding electrode. So it should be at least 6 centimeters away from the generator, pulse generator of the pacemaker. And the electrocartridge burst should be limited to 1 second to every 10-second interval. Something should not use it for a prolonged time. And essential to have equipment for urgent transcutaneous pacing, defibrillation or cardioversion, all should be present. And during insertion, if supposing a need for a central venous line is there, antiarrhythmia and tachyarrhythmia function must be suspended and asynchronous mode must be initiated. And with the patients with bradycardia, avoiding high dose fentanyl and dexmedetomidine is preferable. And patients with long QT syndrome, drugs which cause QT prolongation, like methadone, haloperidol, ondansetron, or high dose inhalation agents are best avoided if you are using GA because of the risk of polymorphic ET can happen. And if the patient is pacemaker dependent, the PM has a program to fixed rate. It's important to realize that tachycardia will not be seen in response to hypovolemia. So careful attention to fluid replacement is very, very important. Then coming to the most important complication which can affect the functioning of pacemaker or AACD is the electromagnetic interference. What is electromagnetic interference? Do you know the answer? Right. It's a potential disruption of the operation of a somatic pacemaker which is in the vicinity of electromagnetic field generated by external source. And interference can be due to electrocartridge perceived by the pacemaker as a intrinsic rhythm of the heart. So any electrical current passing from the electrocartridge, the pacemaker will identify as though it is a conduction or a current from the cardiac contraction, and pulse generation may be inhibited. So it will try to reduce the rate that is applied by the pacemaker. That will lead the patient to bradycardia. So ongoing electrical interference may not be identified by ECG alone. So you have to have a pulse plethysmography from pulse oximeter waveform, or a direct arterial line will show you a missed beat or the real rate of the heart. So this is the plethysmograph all of you are aware of. What pre-op assessment is needed for patients with pacemaker or patient information card will be always present. Whenever a patient has a pacemaker insertion done, they will have a information card along with that, which will give the details of what is the type of disease, model number, what are the indications for insertion, what are the current settings, how many leads are there, everything will be there. So this will be the model of a pacemaker card, patient card. So serial number, right venea lead, RA lead, and all these things are there. And The patient is pacing dependent. There is potential for interference with EMI. The mode of pacemaker should be changed to what is called asynchronous mode. What do you understand by this? Have you all read about this and understood what is this changing from PPM to asynchronous mode? First of all, have you have a basic concept of this pacemaker insertion?
So, asynchronous mode places at the preset rate that is independent of the inherent heart rate. So.
Fantastic. So patient is, despite the contractions from the heart, it will deliver its own stimulation at a particular set rate, so that the patient does not go for severe bradycardia and hypotension. Okay. So converting, earlier it would have been only when there is a delay or the failure of inherent contraction, then the pacemaker will be stimulating the heart at the time. That is the way it is programmed. But once you put the patient under anesthesia, you remove that demand supply type and make it compulsory stimulation at a particular space, so that the risk of hypotension and bradycardia and hypotension is prevented. Okay, that is how it can be programmed. So when patient has an AACD, that is, what is an AACD? What is the expansion?
Automatic implantable cardioverter defibrillator.
Okay, it's a potential for EMI more than the pacemaker, and its defibrillatory function should be suspended in such cases, and it can be done by a programmer. This is a machine called programmer, and this is the magnet that you apply to do that suspension. This is how the magnet is applied, so that you have an idea about how it is done. And these pictures I'm just giving in case it is asked in the OSCE. So reprogramming with a programmer device is essential to have a transcutaneous pacing when the anti-tachycardia function is disabled, as AACD will not respond when there is a ventricular tachycardia. And the advantages of using a reprogramming machine include changing the AACD to asynchronous mode and disabling the rate responsive sensor. And at the same time, you can reset it after the procedure also. So using a reprogramming machine must be done by trained personnel, and changes are not quickly reversible like that of a magnet. So here, if you remove the magnet, it gets possibility of reverting to the original setting. But with programming, you have to reset the whole thing as you want to get back to the old thing. What are the intraoperative emergencies that can happen when a patient with pacemaker is undergoing surgery? The important thing is there may be arrhythmia or bradycardia. Before attempting defibrillation, magnet should be removed and permit reactivation of anti-tachycardia function. Then all sources of EMI should be discontinued. Ask the surgeon to stop the artery, remove the create everything. And failure of rhythm to revert after removal of the magnet will require either defibrillation or cardioversion externally. During occurrence of such event, bedside ECG recording with the paper is helpful to determine the ventricular rate and rhythm. Because whether it is a pure VT or PFib, you will not know by the monitor that you have, which is continuously running. On the contrary, by using a bedside ECG, you can identify them by recording it on the paper. And problems with the device may manifest as inappropriate delivery of shocks or runway highway of 180 to 200 beats, that is in the AACD. So these are the paddles that are used normally. These are the equipments that are used for reverting from VT or VFib intraoperatively. So the intraoperative emergency can be either a bradycardia or a arrhythmia in the form of VT and VFib. So these are the two things which have to be kept in mind and managed accordingly. What is an AACD and the advantage of using it? It's a pacemaker with additional feature to treat ventricular tachyarrhythmia by defibrillation and tachycardia pacing, and it is implanted for primary or secondary prevention of sudden cardiac death in patients who are prone for VT. Whereas a pacemaker is usually given for sinus nerve problems, sixth sinus syndrome, constant bradycardia. Those are the ones which require pacemaker implantation, whereas AACD is mainly for ventricular arrhythmias. Can anyone identify what is this? It's a new thing which has come inside in practice.
Dual chamber pacemaker, sir.
Pardon?
Dual chamber pacing.
Dual chamber pacing. But this is the atrial chamber, this is the ventricular chamber, and this is going through the entire ventricle rather than any lead be sticking here. Do you find any lead coming from the SVC? It is coming from the IVC. Are you able to see?
Yes,
Nothing
yes,
is
sir.
coming from the superior vena cava. Normally, a pacemaker will be implanted onto the which region they implant it?
Oh, the right atrium.
No, the leads will go to the right atrium or right ventricle, but the pulse generator, where do they implant it? The subclavicular region on the left side, usually below the clavicle on the left side, and then they will puncture the subclavian artery to insert the leads, which will go into either the right atrium or right ventricle if it is a by two lead stimulation. Whereas here you find anything going into the right atrium, the entire thick equipment is inside the left. This is called the leadless system, which have a self-contained system which includes both the pulse generator and the electrode within a single unit and is placed into the right ventricle via transvenous approach. Okay? So there will be no pulse generator bulging out on the left side of the chest for these patients. So this is the newer method of implantation. And what is these arrows showing? What is the arrow pointing in this EKG?
Spikes.
Huh?
Pacing spikes.
Pacing spikes. Very good. VVI pacing. That is the lead is. How do you say it is ventricular pacing? When you say spikes, you should say whether it is atrial spiking or ventricular spiking. Do you find any P wave here in this ECG pacing?
No, sir.
So that is the reason why it is called ventricular pacing. Okay. So arrow showing the pacing spikes of ventricular origin. Okay. So just for the ASCII sake, I put it. This is another ASCII question. What is shown here?
Pacemaker.
Pacemakers. You can see the pulse generator here. This is the one which will be usually under the left subclavicular region, which can be seen bulging on the chest. Then there is a lead coming here, one going to the right atrial lead, another one going to the left atrium with the right ventricular lead, right ventricular lead, right atrial lead, and coronary sinus lead. Okay? So this is a permanent pacemaker with bi-atrioventricular leads. And what is this? There's a clue here.
Sure.
So when there's a shock coil, what it should be?
Defibrillator.
This is a defibrillator shock coil. So it's the AACD, implantable cardio defibrillator. Whereas you don't find that shock coil in this. This is a simple pacemaker, whereas this is a implantable cardio defibrillator in the X-ray chest. You can see this is a much more stronger generator, and there is a shock coil which converts or defibrillates the heart whenever required. Right? So that is about TURP. I think we will stop here. I think you all feel that classes are too long and boring. So shall we stop here or shall we continue? The choice is yours.
Sir, I'm on